Dear Chairman, dear colleagues, dear friends, it's a real pleasure and honor for me to give this keynote lecture about osteoporotic thoracolumbar fractures. Over the last 10 years, I've dedicated my research to this topic, and I can say, yes, they do differ, and I would like to give you some insights about them. The point is I have only 12 minutes, so we won't be able to answer all the questions. However, we'll do later on a podcast here with EUROSPINE, so follow us and you will get more information later on through the podcasts. Well, my disclosures are not related to this presentation. Just recently, I was in London at a course, and I gave not a lecture, but I had a meeting about osteoporotic fractures, and I asked the participants whether they would treat these osteoporotic fractures surgically and when. And one gentleman, a surgeon, stood up and said, no, never. And I asked, why? And he said, because they all heal. And that was for me a kind of jaw-dropping moment where I realized, okay, there's a lot of education we have to do because it's not easy like that. So that was an assumption based on probably the last century, but today we know more. You have to consider that 2/3 of the patients with fractures currently are over 70 years old. The data I'll show you are from Germany, but they apply to the rest of Europe as well, and I found data from Asia Pacific, etc. It's more or less over the same. So there was an increase of more than 20% in the lumbar spine and more than 30% of the thoracic spine in these fractures over the last 10 years, and mainly in the elderly patients. And as you know, I assume you probably know, the risk for consecutive fracture is already 20% within the first year. And if the patient has more than one fracture, it increases to 24%, and even more fractures, the higher the percentage gets, they get more and more and more fractures. And this is important to know because it increases mortality of these patients. An example here, 50-year-old lady, otherwise healthy. She complained about low back pain over the last years. In 2018, somebody performed an X-ray, and you can already see that the bone trabecular structure is not really good. She received treatment. But then, in the beginning of this year, she showed up with an increased pain and this fracture, although she was under alendronate therapy. Just 2 months later, she came back with this image, so have more fractures, now consecutive fractures, relatively rapidly. It's important to understand that you can only break your hips 2 times because you have on the left on the right side. It's the same for your forearms as well as your shoulders. But you have 5 lumbar vertebral bodies, you have 12 thoracic vertebral bodies, and you can break all of them. And this leads to the situation that osteoporotic thoracolumbar fracture increase mortality. And our goal, our duty is to avoid this. And that means the patients need medical treatment, medication, as well as surgical treatment if necessary, because surgical treatment can reduce mortality too. Another example, 79-year-old man, sudden low back pain 5 weeks ago, L3 and L4 fracture. Then the pain increased, not only the back pain, but then you started to get leg pain and a kind of neurogenic claudication. So there a spinal canal stenosis developed over the time. And you see here that this fracture in the CT scan doesn't really want to heal. It's more a kind of pseudarthrosis, instability plus the spinal canal stenosis. So about 25% of the patients do not heal, or the fractures do not heal within 6 months. And the ones who do not heal have a higher, definitely higher and significantly higher percentage of low back pain in comparison to the one who heals. So it's very important. And especially the ones, and that's what is the kind of take-home message is, especially the ones who have a T-score less than -3 or Hounsfield units less than 90 are at risk for ongoing kyphosing, sinterin, and disability. So we have to look at this. Because what we want to avoid is that we have to treat them surgically, because the longer we wait, the more aggressive our surgery has to be. So here we performed a percutaneous stabilization with PMMN augmentation plus some kyphoplasties in order to fix the lady from the first, what I showed you in the first example. And the other gentleman got a similar treatment, percutaneous stabilization, augmented screws, and mini open decompression. We can all do this in a minimal invasive fashion. But it's a lot of surgery you have to perform, so we should avoid this. Another example, 86-year-old woman. She had a fall 3 months ago. She is actually not that sick. She has of course, some comorbidities in that age. I can only advise you to use frailty to assess your elderly patients. It's better than sarcopenia. It's more practice. It's more practical in your clinics. Frailty, there are different assessments. The most easiest one is the modified 5-item frailty index. It's, I would say, made for surgeons because it's only 5 subgroups or only 5 items you have to remember. It's really easy. And if you have more than 2 of these items, then the patient has a significantly higher risk of getting any perioperative complication. So you can really nicely assess not only your trauma patients, but in your elective spine surgery patients, in the elderlies, whether they have a higher complication or not. So this lady was not that sick. However, she had an increasing pain, she could not walk freely, she could not stand upright. And when we now look at the images, at the MRI as well as the CT scan, we see that there's almost starting to get fixed, not really fixed because we still see an intravertebral cleft here, but it's getting more and more a situation of a severe kyphotic situation. And additionally, we see that the posterior longitudinal ligament, the PLC complex, this complex gets insufficient. And that's another typical thing. If you wait long enough and the fracture doesn't heal, the ligaments get insufficient and you get these severe kyphotic situations. So here, of course, you need a lot of surgery in order to fix it, because you can't just fix it just in the way it is. So our treatment, what we do, what we have experience with, good experience with, is a combined procedure in that case with a posterior percutaneous stabilization, PMMA augmentation, some decompression, followed then by an anterior mini thoracotomy or even endoscopic procedure where we do a corpectomy and put in a vertebral body replacement. This looks like aggressive, but it can be done in a minimal invasive fashion. And then that's the result. And then you will say, oh, so much metal, so much cement, this won't heal. This will, the adjacent segments, the adjacent vertebral bodies will fracture. But if you restore the physiological alignment of the patient, then there's a higher chance that nothing will happen over the time. So it's important to understand that we have 2 ways of performing the surgery. First is if you have a compression fracture which causes pain, so mechanical instability, then it's mostly enough just to augment maybe the vertebral body or make a short fixation. But in the moment you have a severe kyphotic situation, then you have to do more, to be more aggressive in a minimal invasive way. So that means that you have to perform sometimes an osteotomy or, like we do, anterior posterior, whatever is suitable for you. But if you restore then the physiological alignment of the patient, the outcome is much better. So don't fix them in a kyphotic situation. It's very important to know that there are risk factors for failed conservative treatment. And the most important one, I told you, it's a low T-score of -3. It's when the patient is really frail. And we've heard this already from Enrico Galazzi, if they have burst-type injuries, if they have initial height loss, if they have intravertebral clefts, if they're in thoracolumbar junction, etc., if they have already or developed a sagittal disbalance after the fracture, and some specific MRI fracture types. What we did, we put this together in a classification because we thought, well, here we may help you in a daily decision-making. I would say the beauty of this classification is that it reflects the normal pathway of an insufficiency fracture. It starts typically with a bone edema. Then the end plate gets deformed, then the deformation improves, sometimes the posterior wall gets affected, and then it moves on to a complete burst-type injury, to a pincer type, or to a kind of fishbone thing. And if it still continues, if it doesn't heal, finally the ligaments will fail. So what you can see here is a kind of natural evolution if fractures do not heal. However, 75% of the fractures heal. They stop somewhere in between 2, 3, and 4. So most of them heal, but the others do not heal. And you can see here, you can really judge the fracture and say, okay, what will happen next? So it's helpful. If you have a traumatic fracture in an osteoporotic patient, you mostly have like 0.3 and 0.4. But by just looking at the images, you cannot distinguish whether the patient had a trauma or not. So very important aspects to consider in terms of do I have to do surgery or not is whether the pain is high, whether the patient is in pain, whether he or she is immobile, if you have the low T-score or the low Hounsfield units, of course, if you have a neurological deficit, and if you see an ongoing kyphosing over the time. And of course, the patient, that's the majority, who are mobile, who have moderate pain, can be treated conservatively. We put this together in a score. The score is just a summary of all the important data we found in order to give you, again, a help, in daily practice to decide, does this patient need surgery or not, or can we go on with conservative treatment? What would be the first choice? And here the score can be taken every day on an everyday basis. We evaluated this score in Germany over the last years, and 1/3 of the patients, we had more than 500, were treated conservatively and 2/3 surgically. And typically people say, well, if you go for surgery in these elderly patients, you have so high complication rates. We had only 13%, and the vast majority were medical complications. Deep venous thrombosis, urinary tract infection, things. Surgical complications were rare, but the most important thing is all patients did well afterwards. They all did well, almost all, 97%. We have published this, so it's open access if you're interested in. It's published in Global Spine. We have published our sub-analysis of the 004 and 005 fracture, or 2. We will just very soon send off the paper about the 003 fracture, so if you're interested in this treaty outcomes, what we have done, just read them. The OF score has been evaluated internationally, from Japan, for instance, and the Japanese colleagues retrospectively reviewed 240 patients. And what they found is that this score identified patients who required operative treatment with a high degree of accuracy. And just another paper was submitted from Thailand. Again, they did a retrospective review, 160 patients, and they found that this score is reliable and valid with good discriminative ability for surgical decision-making in these patients. So, because I have only 12 minutes, I have to conclude already. These fractures differ. They shorten patients' life, and they do not heal in up to 25% of the patients. So it's your duty to have a look at them, to follow them, to identify the patients who are at risk, to look at them and to interfere if necessary early enough. Because what we want to avoid is this huge aggressive surgery, what I showed you with anterior-posterior. You can do this if you do it frequently, but it's still there's a chance that patients get complications. The OF classification, the score, are evaluated. They're evaluated tools which may help you for decision making. If you're interested in, I brought some of these pocket cards made by the AO. We have a lot of them, so if you're interested in later on, just come and get some, for your doctor's code. You can use them in daily practice. And very important, don't forget the medication. If you don't treat the patients with medication, they will come back and back. And bisphosphonates are not good enough, especially if they had already a fracture. You need anabolic drugs. And by this, I would like to thank you very much for your attention. I'm happy to answer your questions.
So thank you, Klaus, for your excellent talk and your work you did. I think we all know that it's a very difficult kind of treatment we have to perform. Next step of your excellent classification, do you think we need any modifiers? Because I showed you in the first wrap-up in the CT scan that I personally learned the vacuum phenomenon you see sometimes is something I would rather go for surgery earlier than I did before. Do you have some of these tricks for us?
Yeah, well, so definitely this classification is something we developed over several years ago to give a kind of overview and to help to classify the fractures according to their grade of instability. But yes, we know that if you have multiple fractures, if you have maybe a fracture adjacent to an old fracture or adjacent to a further previous stabilization, if you have intervertebral clefts, all these are modifiers, it's totally correct, which then may lead to the situation that you have to probably start earlier with your surgery or be more aggressive or whatever. As I said in the beginning, still we are struggling to convince our surgical colleagues to look at these patients and to realize that they need treatment. So while we in Germany are probably quite aggressive in treating them, outside, in the rest of the world, sometimes there's just a neglect. So these patients do not get treatment at all, and this is the problem. So yes, there are modifiers. We should probably, adopt the classification and put something in, but I don't see first of all, I see the necessity to convince surgeons worldwide that they have to have a proper look at these patients and treat them according and early enough.
Okay, there's a question from the audience. So it's also regarding the aggressiveness of the surgical procedures for this case, this 86-year-old woman. What do you think about 3 levels up and down and cemented screws to avoid the corbectomy, or when do you perform corbectomy?
Yeah, so this, well, maybe because of shortness of time, they couldn't realize that the kyphosis was relatively fixed. So we did a hypomocleon, so we put them on the supine with a pillow, and we just saw kind of 5 to 10 degrees open up. So there was no reduction. If you fix the fracture in this kyphotic situation, then the sagittal, you fix patient in a decompensated sagittal situation, and then it will fail. It will definitely fail. So no matter if you put 3 screws or 4 screws above, no matter whether you put cement or not, it will fail. So in these cases, I think you need to restore the physiological alignment. You can do this from the posterior by performing an osteotomy, but I think the problem here is that you have a lot of blood loss. And when we stage the surgery like we did, we have posteriorly we have 50 cc, and anteriorly we have 200 cc blood loss. So the patients actually, do quite well if we stage the surgery, if we don't do it in one surgery, and if we use minimal invasive approaches from back and front. So it looks aggressive, but at the end is that aggressive, But of course you need routine to do that.
Yes. Another question about the follow-up in conservative patients with X-ray controls, and especially in patients who present already with a slight kyphotic situation. So how often do you scan them?
Yeah, so typically what we do, if we have a patient coming in the casualties with this fracture and pain, we start treating them conservatively. Then in the moment the patient is able to stand up, we make an upright standing X-ray. And then, if the patient is doing fine, we discharge them. And then within 2 weeks, you should make the next X-ray control, standing X-ray control. So 2 weeks is 1 to 2 weeks, so depending on the opportunities you have. So 2 weeks is fine, and then if you see, then of course they develop a little bit of kyphosis. But if they quickly, develop kyphosis or sintering of the vertebral body, then you should probably interfere. And mostly it comes along with pain. So 2 weeks, I would say, within the first 2 weeks, you should check the X-ray.
So perfect. So we are just in time. We thank you for being interested in this talk. Please go to the industrial part now, and we see you later at the second day of this Congress. Thank you.